Welcome everyone. I would like to present my progress so far in these 6 months in my PhD called the Hungarian pharmacist position in the healthcare system. Throughout my residence year, I struggled to find common practice in the clinical pharmacy services because in Hungary there is no guideline or protocol how to do our services. And my vision is therefore every pharmacist, every ward should have a pharmacist in their rounds because they have a special knowledge about medication. And to support this vision, I would like to establish clinical pharmacy services in Hungary. And to support this vision, I have 3 ongoing investigations. First of all, I would like to investigate the impact of clinical pharmacists in Europe. It will be an international survey because clinical pharmacy services are not common, not just in Hungary, or moreover in Central or Eastern Europe, and there is no official benchmarking system for these clinical pharmacist services, and we don't know the impact of our work. And with this international survey, this is a 3-step approach. First, I would like to map out the clinical pharmacy services in Europe to determine what are the positions of the pharmacists in the hospitals and to discover the most common practices. And there I would like to do a systematic review about these services and how to measure these. With this project, we are in the finalization of our questionnaire, and we would like to distribute it in the near future in symposiums and conferences. And what else could a pharmacist give to the patients? In my practice, I would like to help acute pancreatitis patients in a new way to treat medically the patients. Acute pancreatitis is the sudden inflammation of the pancreas. Its incidence rate ranges from 5 to 100 cases per 100,000 inhabitants. Its mortality is highly dependent on the severity of the episode of the acute pancreatitis. In the mild form, it could be self-limiting. However, in the severe form, it could reach 40% mortality. To this day, there is no efficient pharmacon, but in the 2010, ulinastatin raised, and it could be efficient pharmacon against pancreatitis. It is a urinary trypsin inhibitor. It could prevent activation of several pancreatic enzymes, thus avoiding the autodigestion of the pancreas. And our aim is to investigate this therapy. Our comparator will be somatostatin analogs because we decided that somatostatin either or its more potent analog octreotide doesn't have a significant effect compared to placebo, so it is not inferior nor superior to placebo, and it has got the same mechanism of effect, and we decided to match this together and compare our combination therapy with this. Our hardest outcome, after the process of the selection, we conducted our research in 4 databases, and we included 9 randomized clinical trials in this analysis. Our hardest outcome is mortality. The combination therapy shows beneficial effect on this. 45% of the time it could prevent death. However, it is not statistically significant, but if you think about the clinical implications, we could almost save every second life with this combination therapy. And throughout the progress of the acute pancreatitis, several complications can arise. For example, acute respiratory distress syndrome. The combination therapy shows, again, a beneficial result. 70% of the time it could prevent this complication. However, there is a moderate amount of heterogeneity in this outcome. Furthermore, acute kidney injury also could be prevented by the combination therapy by 70% with a moderate to high heterogeneity of the data. Multiple organ distress syndrome also could be prevented by the combination therapy by 60% with low heterogeneity, and also shock could be prevented by the complication therapy it could be prevented by 50% with moderate amount of heterogeneity. This moderate to high heterogeneity, it is because the low amount of included studies, and therefore there should be more clinical randomized trials to draw a final conclusion. And in conclusion, with the less complication rates, the length of hospital stay will be shorter. With the combination therapy, the length of hospital stay could be reduced by 9 days. However, there's a high heterogeneity in this outcome because the acute pancreatitis patients have got a mixed background. They could be healthy or diseased patients, and it's a very mixed patient population. Throughout the analysis, we have the moderate to high risk of bias due to the low number of clinical trials and the blinding of the included trials. The strength of this analysis is that this is a new potential tool in the treatment of acute pancreatitis, and we conducted our research with high standards following guidelines. The limitations are there is few and moderate quality trials, and the applied therapies and the follow-up times are very different in the articles, and the conclusion is that the combination therapy shows beneficial effects in every investigated outcome, and it could be a possible new drug therapy treatment for acute pancreatitis. However, there should be new high-quality randomized clinical trials to have a final conclusion, and we should have a cost-effectiveness analysis too to find the best place for this therapy. And staying with acute pancreatitis patients, I would like to investigate the effect of proton pump inhibitors, because on admittance, 20% of the patients have some kind of proton pump inhibitors prescribed, and during the hospitalizations it rises to 70%. It is one of the most overused drugs in the field of medicines. However, there is no acute pancreatitis guidelines that recommend or avoid use of PPIs in acute pancreatitis. In theory, PPIs can reduce secretion of amylase pancreatic juice in experimental settings. Our aim is to investigate the effect of PPIs in acute pancreatitis. We would like to compare PPIs versus no PPIs, and we would like to measure the adverse events, laboratory parameters, and symptom reductions. And our hypothesis is that PPIs are inferior to placebo. And the clinical implication would be the decrease in adverse events. After we are in the process of the abstract selection, which we concluded yesterday. We have 11 trials in this field. And we are in the finalizing of the second project of the manuscript, and I would like to end my presentation with a statement that never stop asking questions, because it will lead to answers. Thank you very much.
Thank you. Can we go back to your first results, please? Because I have a comment to almost all. So here, I have to say that all of the included studies were severely underpowered for mortality, correct?
Yes.
Yeah. So you should really make a statement on that. So that's really a limitation of this result, although it is non-significant, right? Yes. Move to the next one, please. This same here. It's a very low event rate in both groups. So that's just a limitation. And please move on. Yeah, this is just a typo. It's multiple organ dysfunction syndrome. Okay? Not distress. Because it's ARDS is distress, but this is dysfunction. Just, okay? And And go to your next slide, please. Yeah, this is too good to be true. 9 days, or 9.5 days. I mean, all studies came from China, if I'm correct, but this is really too good to be true. So, are you not suspicious with this result?
I'm always suspicious. They included severe form of pancreatitis, so it could be the answer for this.
I would tear these articles piece by piece and try to find the catch, because that stinks to me. This is really, I mean, it's amazing, 9 days reduction. Yeah, and please move on. The strength is not a new potential tool in the therapy, because this is the clinical implication. So you should rephrase this part. I mean, you included randomized trials, so you need the strength of your work, not the therapy. If you know what I mean. It's just, yeah, okay. But that's it. Thank you.
Thank you.
Thank you very much. And so, especially the first project is much interesting, because it seems like you put a lot of effort, and so I think the implication is soon. And I just want to ask some question regarding the last slide. Can you go to the very last slide? Yeah, I just want to ask this framework, because it seems like during the first report you were mentioning you made this kind of framework, and could you please explain what does it mean? And yeah.
You should always ask the specific questions to have a specific answer.
I mean, this framework, this table, yeah. You told us like you made this framework by yourself based on your project. No?
I didn't do it.
Ah, no, I see. Okay. I got it wrong. Thank you.
So I just wonder, I mean, I understand that this proton pump inhibitors, so I mean, may be overused. But since you stated that in animal models, actually, when you block this, that you block pancreatic secretion, so why do you assume that this is inferior, which would mean actually a negative effect in my mind and not neutral?
With our preliminary research, we couldn't find any good results with PPIs in acute pancreatitis.
Yeah, but I would phrase it as just ineffective. Because probably what you will get, I mean, this is just an assumption, but probably you will not get a negative effect, you will just get no effect. I mean, this is what I see.
Okay.
But maybe I'm wrong, I mean, just, this is about discussion.